morning everyone. Myself Dr. Parag Tamberi. I am working as an assistant professor in cardiology at UNMICRC Institute of Cardiology and Research Center, Ahmedabad. So topic for today is basics of rotablation and calcified coronary lesions. So as we all know, calcification is associated with coronary atherosclerosis, and in current era of PCI, where more and more of CABG is being turned down and more of complex PCI is being taken up, dealing with coronary calcification is one of the important challenges in the cath lab for the cardiologist. Up to 20% of patients undergoing PCI are estimated to have moderate to severe coronary calcification. Calcium hinders proper device delivery, and hence aggressive plaque modification is necessary to facilitate proper stent delivery, which in turn allows proper stent expansion, a good opposition, good luminal gain, acquire adequate MSA, and also to minimize complications, which in turn replicates into a good short and long-term outcomes for the patient. So what is the impact of coronary calcification on the PCI? What studies do we have? So this data is being taken up from two studies, Horizons AMI and Acuity Coronary Calcium Study, which was published in 2014. So this study studied 1 year outcomes of the enrolled patients. 6,800 patients were enrolled and were divided into three groups. Cases with no or mild calcification, moderate and severe calcification, and 1 year outcomes of all-cause mortality, cardiac death, MI, target vessel revascularization, and MACE were studied. So as we can see, as the amount of calcification increases from moderate to severe, the outcomes are also worse. Similarly, this is a meta-analysis of 7 studies which was published in Heart Journal in 2014, which studied a 3-year outcome of PCI done in calcified lesions versus non-calcified lesion. So the incidence of death and MI after 3 years was significantly higher in patients with severe coronary calcification, and the p-value was significant. This is another study, ADAPT-DES, which included 8,500 patients and studied a 2-year outcome of target vessel failure, which was significantly higher in patients with coronary calcification versus no calcification. Okay. Similarly, what about data from left main PCI? So this data is taken from Excel trial, which included 1,850 patients, and a 3-year outcome was studied. So the 3-year death, MI, and stroke rates were significantly higher in patients with moderate to severe calcification as compared to mild or no calcification. So what does all these data tell us? It implies that presence of coronary calcification does have a poorer prognosis as compared to no calcification. So this is a coronary angiogram. So on the left side panel shows angiogram of right coronary artery taken in LAO view. We can see there is significant calcification right from the ostium of the RCA till the distal vessel. Also there is a significant lesion in the proximal and mid RCA, and the vessel is quite tortuous. On the right panel we can see angiogram of the left coronary taken in a PA cranial view. We can see there is a significant lesion in the proximal LAD, and also there is significant calcification. This is another angiogram of the left coronary taken in ariocaudal view. We can see there is a lesion in proximal LAD. This is another PA cranial view of the same patient. There is a significant lesion in the proximal LAD. Diagonal is also deceased, and there is associated moderate to severe calcification. So now that we have seen the angiograms, is coronary angiogram a good modality to detect calcium? Yes, it is, but coronary imaging is much better in terms of detecting coronary calcium, and as well as detecting, quantifying, and also to study the characteristics of calcification, which can be done by intracoronary imaging. So this study was published in JACC in 2017. which included 440 patients which had underwent CT coronary angio to detect the calcification. As we all know, CT is a good modality to detect calcium, and all these patients were subjected to CT coronary angio, and then they were also posted for coronary angio and intravascular imaging. What they saw was coronary angio could only detect calcium in only 44% of cases, whereas intracoronary imaging like IVUS and OCT could detect 77 and 83% of calcium respectively. So this implies that calcium detection and studying the characteristics of calcification is done much better with intracoronary imaging, and hence if we are planning a PCI in a calcified lesion with rotablation, including intracoronary imaging is very important for deciding our PCI strategy. So this is an example of how a calcium would appear on IVUS imaging. So the calcium is quantified by measuring the arc it encompasses. It is also classified by the location, whether it is superficial or deep. So this is the example of calcium assessment on IVUS. In the top left panel, we can see there is severe calcification, severe superficial calcification, and it encompasses an arc of more than 270 degrees. Also, we can measure the length of the calcium on the IVUS. This is another example of calcification on IVUS. The top left panel shows calcification from 5 o'clock to 7 o'clock position and encompasses an arc of 80 degrees, which is considered as mild calcium. The center panel shows calcium with an arc of 110 degrees or moderate calcification, and similarly the right panel shows more than 270 degree calcium arc or severe calcification, which is a superficial calcium. Similarly, OCT is also a very good modality in detecting calcium. The OCT has lesser penetrance, but it has higher resolution, and hence the calcium can be quantified, and the calcium characteristics are much better studied with OCT as compared to IVUS. So the sharp bordered signal poor tissue is the calcium, which we can see in the top left panel. It encompasses almost 360 degree calcium around the lumen. In the second panel, we can measure the thickness of the calcium in a much better way as compared to IVUS, and also we can measure the length of the calcium. These are the examples of calcification on OCT. In the left panel, we can see that there is moderate calcification from 9 o'clock to 2 o'clock position, encompassing 130 degree arc or moderate calcium. On the right panel, we can see severe calcification on the OCT image. So now that we have seen how to image the calcium, now let's talk about how to modify these calcified lesions. So we have many options like balloon-based technologies and atherectomy devices. Balloon-based technologies include our regular non-compliant balloon, a high-pressure balloon or a OPN balloon, a scoring balloon like angiosculpt, a cutting balloon like a Wolverine cutting balloon, which has longitudinally mounted sharp cutting blades which cut through the calcium, and also intravascular lithotripsy, which emits high frequency signals and causes cracks in the calcium. And atherectomy devices include rotational atherectomy, orbital atherectomy, and laser atherectomy. We are going to discuss more about rotational atherectomy. So what clinical evidence do we have? So back in balloon angioplasty era, studies showed rates of wrist stenosis with rotational atherectomy of approximately 40%, which was similar to use of balloon angioplasty alone. So it was quite high. Following which, during bare metal stent era, the absolute restenosis rates ranged between 20 to 30%. But with advent of drug-eluting stents, neointimal proliferation was significantly inhibited, and rates of restenosis and TLR were reduced. Several studies have reported favorable intermediate and long-term outcomes with adjunctive rotablation before drug-eluting stent implantation, with target lesion revascularization rates of less than 10%. So this is a ROTAXIS trial which was conducted in 2013, which studied the efficacy of rotablation over conventional balloon angioplasty. So 240 patients were enrolled in between 2006 and 2010, and they were randomized in 1:1 fashion to rotablation followed by disimplantation and other group of standard therapy. So 9-month follow-up of the patients showed that in between two groups, that is standard therapy versus rotablation, the minimal luminal diameter stenosis, late lumen loss and binary stenosis were similar, and the p-values were insignificant. And hence, based on this result, the study was concluded that balloon dilatation with only provisional rotablation remains the default strategy for complex calcified lesions before disimplantation. And based on this study, rotablation was not recommended as a routine use. However, another study, the randomized PREPARE-CAL trial, included 200 patients with severely calcified coronary artery disease which were amenable to PCI were enrolled. They were randomized in 1:1 fashion. One group underwent PCI with a cutting or a scoring balloon followed by disimplantation, and another group underwent rotational atherectomy followed by disimplantation. So at 9 months in this study, instant late lumen loss was not different between the two groups. Also, the target lesion revascularization, probable or definite stent thrombosis and target vessel failure rates were much lower than previously reported and not much different between the two groups. And hence this study concluded that in modern PCI, upfront rotablation prior to contemporary DES implantation in severely calcified coronary lesions was feasible and associated with a greater success without increasing late in-stent lumen loss. So what are the indications for undertaking rotablation? So rotablation is primarily indicated for modification of severely calcified balloon undilatable de novo coronary stenosis. For severe calcification on IVUS, defined as an arc of superficial calcium involving more than 3 quadrants, but only superficial. For deep calcification, rotablation is not a good modality. IVL or a cutting balloon, other modalities are better, but for superficial calcium, rotablation is indicated. Also, OCT measures of coronary calcification are predictive of stent under expansion. So parameters like calcium length more than 5 mm, arc more than 180 degrees and a thickness of more than 0.5 are indicative of stent under expansion, and in which rotablation should be considered. And overall, operators should have a low threshold for adopting a planned rotablation strategy. Rotablation can be an effective treatment option in patients with calcified unprotected left main disease who are not eligible for CABG. So ROTATE registry studied efficacy of rotablation in left main disease. So in this study, as there were no differences in the rate of in-hospital MACE between unprotected left main versus non-unprotected left main, but 1-year MACE was significantly higher in the unprotected left main group, which was largely driven by target vessel revascularization. Similarly, definite and probable stent thrombosis was also higher in unprotected left main group. And hence, although feasible, rotablation of unprotected left main is associated with worse outcomes, likely due to a larger territory of myocardium being jeopardized. And hence, if undertaken, should be done in a meticulous technique with experienced operators and with surgical backup. Being said that, rotablation is an excellent adjunct in treatment of protected left main disease in patients who have underwent CABG due to a high prevalence of fibrocalcific disease in this patient population. So rotablation was also being successfully done in 16 patients for treating ISR, which was resistant to balloon dilatation. So the study published by Ferry et al. Reported an increase in minimal luminal diameter from 2.3 mm and a decrease in diameter stenosis from 82% to 11%. So significant reduction in diameter stenosis. There was one case of burr entrapment which was managed percutaneously. So rotablation can be used in ISR patients, as we do have data, but the sample size or the patients, only 16 cases were included. But there is a lack of consensus for use of rota in ISR. Similarly, another study of 200 patients undergoing rotablation for ISR, which showed a 12-month TLR rates were lower. So this study basically compared rotablation versus drug-eluting balloon for treating ISR. So a 12-month TLR rate was lower with drug-eluting balloon, 27%, compared to conventional angioplasty, which was 40%. So suggesting that for severe ISR requiring a debulking strategy, a drug-coated balloon angioplasty following rota ablation might be a most effective option. However, consensus is still lacking, and rota ablation, if being taken up in ISR, should be done by experienced operators and with a surgical backup. So what are the contraindications? Rota ablation is not recommended for degenerated saphenous venous grafts due to high risk of distal embolization, any thrombus containing lesion, evidence of intimal dissections, severe tortuosity, and other relative contraindications include lack of on-site surgical backup, severe triple vessel disease, unprotected left main disease, severe LV dysfunction, lesion angulation more than 45 degrees. So although successful rota ablation have been reported in these conditions, but these are considered as relative contraindications. So rotational atherectomy is reasonable for fibrotic or heavily calcified lesions that might not be crossed by balloon catheter or cannot be adequately dilated before stent implantation, and is currently a class 2A recommendation. So now that we have talked about all the studies and indications, contraindications, let's come to the actual rota ablator and let's talk about the hardware. So the commercially available rota ablator was brought out by Boston Scientific and was first introduced by David Oth and colleagues in 1988. So here we can see the rota ablator system. So this case encases a motor which is mounted on a drive shaft, and this drive shaft is further connected to its tip to the rota ablator burr. So this housing has two connections, one connection for compressed air, another connection for the fiber optic cable, and the third connection for saline infusion which drips through the rota ablator. It also has an advancer knob on the top which can be used for advancing the burr. And similarly, there is a wire clip on the posterior aspect of the console. This is a rota ablator console in which the RPM of the burr can be controlled. We have a foot pedal which has basically two switches. On the left side, the switch is for activating and deactivating the burr, and on the right side for activating, deactivating the Dynaglide mode. So what are the burr sizes we have? So burr sizes are available from 1.25 to up to 2 and even 2.5 mm with increments of 0.25 mm. So the most important part of the rota ablator is the burr, of course. So the burr is an elliptical nickel coated brass burr which has 2000 to 3000 microscopic diamond crystals on its leading face. The diamond crystals are 20 micrometer in size and they only protrude 5 micrometer from the nickel coating. And the trailing edge of the burr is smooth. And the burrs are available in various sizes as we have discussed previously. So the burr has this leading edge which has diamond coating which is passed over a guide wire. It has a drive shaft which is connected to the motor and which has a protective sheath over this drive shaft so that it doesn't damage the proximal coronary. So what is the mechanism or principle on which the rota ablation works is differential cutting. So basically how it works is the diamond crystal basically deflects the elastic tissue seen in the left panel, whereas in the right panel the inelastic tissue or the fibrocalcified part of the lesion is being forcefully broken down, and selectively only the calcified part is broken by the diamond crystal, and the elastic tissue or the normal tissue is deflected away from the burr. So the rotablator is advanced over a coronary wire, and two wires are basically used for rotablation, a rota floppy and a rota extra support. So rota floppy wire is used more commonly. It is a long wire, 325 centimeters in length. It is flexible and is torqueable, and it significantly reduces guide wire bias, and it is a 009-inch guide wire. A rotaglide lubricant is used, which is used to reduce the friction, and it significantly reduces heat generation. So this solution contains verapamil and nitroglycerine, which is added to a 500 ml heparinized normal solution, and which continuously drips from the tip of the rotablator, and it's basically used to reduce heat generation, and it also reduces sudden drops in the RPMs. So now coming to the actual procedure, what all things are necessary before starting the rotablation. So patients are pre-treated with aspirin and a P2Y12 inhibitor prior to the procedure. A glycoprotein 2B3A inhibitor can be used as it has shown benefit in limiting speed-dependent platelet activation. A rotaglide solution is used to reduce the heat generation and friction. A temporary pacing wire can be used for rotablation in a RCA or dominant circumflex due to risk of profound bradycardia. Adenosine released during the RBC fragmentation during rotablation leads to bradycardia. What access, both femoral or radial access can be used, but radial access is preferred. A 6 French guiding catheter is enough for burrs up to 1.75 mm, but a 7 French catheter is preferred for burrs more than 2 mm. So the guide must be coaxial to the vessel to avoid wire bias. So once the guide wire is coaxially engaged, a workhorse guide wire like a BMW wire is crossed across the lesion with a microcatheter, and then the rota floppy wire is exchanged over it. So the floppy wire is more flexible. It has a longer taper over 13 mm and has a shorter spring tip, that is 2.2 centimeters. So which causes less vessel straightening and reduces the wire bias and permits the atherectomy at a greater curvature of the angulated lesion. Whereas the extra support wire has a shorter taper, and it causes more wire bias and is useful for ablation at the lesser curvature of the angulated lesions, which we'll discuss even more detail in the next slides. Okay. So to avoid wire fracture or burr lodging, the wire should be parked as distal as possible. A single 1.5 mm burr usually suffices for a vessel less than 3 mm diameter, but a larger burr of 1.75 or more should be used in vessels more than 3 mm in diameter. Also, larger burrs are required for aortosteal lesions. So regarding the burr sizing, this study to determine the rotablator and transluminal angioplasty strategy, the STRATA study, was done, which enrolled 500 patients and were randomized into two groups. One group had an aggressive strategy and the other had a routine strategy. So in aggressive strategy, the burr to artery ratio used was 0.8 to 0.85, which was a larger burr, as compared to a routine strategy, the burr to artery ratio of 0.7 to 0.75. So what was found that the results the residual stenosis, the clinical success, the 6-month results of target lesion revascularization, etc. was similar in both the groups. But in the aggressive strategy, the complication rate was slightly higher. and hence a routine strategy is preferred over an aggressive strategy. Similarly, regarding the rotational atherectomy, the RPM of the rotabur should be kept between 1,40,000 to 1,60,000 revolutions per minute, and studies have shown that with higher rotational speeds, more platelet activation can be seen. So before going ahead and doing the rotablation, we have to set up the rotablator. So during setting up, now that the lesion is wired and we have our rotafloppy wire deeply placed into the coronary, we have to advance the ablator over it and advance it in the coronary. So before advancing, the acronym DRAW is used to make sure that everything is in check. So D for drip. So the rotablator tip should be dripping from the saline solution, which is mixed with rotaglide. So the drip should constantly be on. The rotation is checked before introducing the burr into the guide, and the rotational RPM is being set before introducing, usually set between 1,40,000 to 1,60,000 RPM. A is for advancement, so the advancer knob over the housing is being checked whether the burr is freely moving or no, and finally W, that the wire should be clipped behind so that the wire does not go ahead. So what are the fundamental elements for optimal rotational atherectomy? A single burr with a burr to artery ratio of 0.5 to 0.6 is recommended. A rotational speed of 1,40,000 to 1,80,000 RPM is recommended. Gradual burr advancements with pecking motion is to be used. Shorter ablation runs of 15 to 20 seconds are recommended, and avoidance of decelerations more than 500 RPM is recommended, and a final polishing run should be done. So this is an example of how the rotablator is advanced into the lesion with pecking motions. So in between the runs, once all the runs are done, the rotablator is then removed in the dynaglide mode, and everything is made sure that the hemodynamics are good and the vessel is flowing. So what are the complications? Let's come to the last part of the presentation, a few complications. So what are the complications associated? So bradycardia and AV blocks, slow flow or no reflow phenomena, coronary dissections, coronary perforation, side branch occlusions, or hypotension. And similarly, rotablator system failure includes burr entrapment, burr detachment, and guide wire fracture. How do we manage AV blocks? So basically, prevention is better than cure. So you prevent AV blocks by limiting the ablations to less than 15 to 20 seconds, pre-treat the patient with atropine before the run, and deactivate the burr when a slowing of heart rate is noted. So another complication, slow flow or no reflow, is also seen at times. And the potential mechanisms include atheromatous debris embolism, platelet activation and aggregation, microcirculatory vasospasms, vasovagal reflex, or intraprocedural hypotension. So this can be avoided by using a relatively smaller burr, optimal antiplatelet therapy prior to therapy, use of a GP2B inhibitor, and use of intracoronary vasodilators. So as we discussed, we should avoid longer runs. We should limit the ablation run to 15 to 20 seconds. A drop in RPM should be less than 5,000. It should not be more than 5,000. If at all the drop is more, we should take a small break in between. Increase the time between the ablations and use a slower speed of 1,40,000 if slow flow or no reflow is been seen. Coronary dissections are usually seen in moderate to severe angulated lesions, which are more prone for dissection, as the burr does not follow the normal course of the vessel. Because of guide wire bias, the burr can actually dissect the vessel. So placement of guide wire plays an important role in establishing the cutting vector of the device. So So the guide wire, basically the divergence of the guide wire from the central axis of the vessel causes an unfavorable bias. Like for example, if we have a tortuous vessel, the guide wire will be biased towards one edge, and here we can see that the guide wire is biased towards the lesser curvature, and the burr would actually drill through the normal vessel and not through the plaque, and this is where there is a risk of perforations and dissections. So how to minimize the guide wire bias? So by retracting the rota guide wire, slight retraction in the proximal position may improve the coaxial alignment of the lesion, and also making sure that the guide wire is coaxial with the vessel, which can minimize the guide wire bias. Perforations, again, incidence is 0.7%. Mechanism is generally because of oversized burr or guide wire bias, and is more commonly seen in angulated lesions. So it could be avoided by minimizing guide wire bias and a proper guide engagement, undersizing the burrs in severely angulated lesions. A pecking technique should be followed meticulously. If at all a perforation has been encountered, a balloon tamponade should be applied. If it doesn't work, then the ping pong technique should be used, and another access with another guide with a covered stent can be placed if needed, and pericardiocentesis or mechanical circulatory support should be used if necessary. Another complication includes rotablator system failure. So despite mechanical complexity of the system, device failure is rare, but we can see burr entrapment and guide wire fracture. So how to manage the entrapted burr? So vigorous intracoronary vasodilators can be used and try and remove the burr. Pulling back on the rotablator system manually can be tried, but care should be taken not to forcefully pull the system back, as it can damage the proximal coronary. So what can be done is use another guide and a second, or from the same guide we can use another guide wire, try and cross the wire underneath the burr and try and balloon it with a small 1 mm balloon, and try and relieve the entrapted burr. Or what we can do is we can cut the the sheath over the drive shaft. So the proximal part of the rotablator can be detached from the main part, and from which we can see that the rota shaft is been uncovered, and the sheath over the drive shaft can be then cut, making sure that the underlying guide wire is not cut, and the sheath is then removed completely, and over this sheath a guide extension or a guidezilla can be passed right up to the rotablator, and with the support of the guidezilla, the entire system with the burr can then be manually retracted and can be brought out. So if we do come across a stuck rotablator burr, this protocol could be followed. So first use a second guiding catheter and try and recross the second wire, and over this wire a balloon can be passed, and with the help of balloon the burr could be tried to retract. If this doesn't work, then cut off the sheath and remove the outer cover of the ablator, and over the drive shaft of the ablator a guide extension or a guidezilla could be passed, and then the system could be withdrawn. If this also fails, then final is the surgical removal or CABG. Thank you.